Welcome to our video on diabetes during pregnancy. Let's get started. Here's our overview slide. We'll be discussing gestational diabetes mellitus, fetal complications, and pregestational diabetes mellitus. Let's start with gestational diabetes mellitus. For each condition, we'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, management, and follow-up. Let's begin with gestational diabetes by reviewing the definition. Gestational diabetes is a type of diabetes mellitus starting after 20 weeks gestation. In order to diagnose this, the patient should not have a history of diabetes before pregnancy. All right, now let's discuss the pathophysiology. Syncytial trophoblasts of the placenta produce a hormone called human placental lactogen, which normally increases insulin resistance. Insulin resistance results in hyperglycemia, which in turn stimulates insulin release in high amounts. This phenomenon is called compensatory hyperinsulinemia. While most women can release sufficient insulin to overcome insulin resistance, some cannot. In these patients, the pancreas cannot sufficiently upregulate insulin production, resulting in persistent hyperglycemia, that is, gestational diabetes mellitus. Okay, moving on to risk factors. Obesity is a well-documented risk factor for gestational diabetes mellitus. Additionally, a family history of gestational diabetes mellitus in a first-degree relative contributes to a woman's risk for this disease as well. Finally, a history of GDM in prior pregnancy also predisposes the patient to have this condition in the current pregnancy as well. All right, let's try a quick question. Which hormone plays an essential role in the pathogenesis of GDM? All right, as we discussed on one of the previous slides, human placental lactogen is the hormone that induces insulin resistance, and in some cases, GDM. All right, now let's talk about the clinical features. Signs and symptoms of GDM in a mother are not any different from features of pregestational diabetes. A pregnant woman with GDM typically complains of polydipsia and polyuria, and has moderate to severe glucoseuria as well. As for the fetus, there are multiple clinical features with distinct mechanisms. Fetal hyperglycemia caused by transplacental transfer of glucose increases the metabolic demand in fetal cells and causes excessive oxygen consumption. This in turn results in hypoxia, which stimulates erythropoietin production from the fetal kidneys, giving rise to polycythemia. Organomegaly is explained by the fact that insulin is an anabolic hormone and it causes glycogen and fat deposition in the tissues. Diffuse glycogen and fat deposition will eventually cause macrosomia, which means that the fetus will be large, weighing more than 4 kilograms. Neonatal hypoglycemia results from persistently elevated fetal insulin levels. Once the baby is born, he or she is no longer exposed to high glucose from the mother, so the increased insulin in the baby's blood will decrease glucose concentrations and result in hypoglycemia. Finally, birth trauma, such as brachial plexopathy and shoulder dystocia, are caused by macrosomia and cephalopelvic disproportion. Let's discuss brachial plexopathy in more detail. There are two major types of brachial plexus lesions, Erb palsy and Klumpke palsy. Both of these conditions have a good prognosis if they occur as birth trauma. Most infants gradually regain the function of the affected upper extremity. Erb palsy is caused by lateral traction on the fetal neck during delivery. It's associated with damage of the upper trunk, that is the C5 to C6 nerve roots, which causes the characteristic waiter's tip deformity of the hand. Klumpke palsy, on the other hand, is caused by upward force on the fetal arm during delivery, and this is associated with damage of the lower trunk, so C8 to T1, and this causes the characteristic claw hand deformity. These two conditions are discussed in great detail in our lecture called Common Peripheral Nerve Injuries. On this image, you see a waiter's tip deformity, which again is characteristic of Erb palsy. Hopefully you can appreciate this adducted, extended, and pronated arm. This image shows us the characteristic claw hand deformity of Klumpke palsy. Notice the flexed distal interphalangeal joints and the proximal interphalangeal joints. Now let's discuss shoulder dystocia. Shoulder dystocia is when the anterior fetal shoulder gets lodged under the maternal pubic symphysis after the fetal head is delivered. As we mentioned in one of the previous slides, this is due to fetal macrosomia. It's important to know that shoulder dystocia can lead to brachial plexus injury. We cover shoulder dystocia in great depth in the lecture called Complications of Labor and Delivery, so we're not going to go into too much detail here. However, it is worth reminding ourselves that shoulder dystocia is a true obstetric emergency, and it requires special maneuvers for successful management. Here is an illustration of shoulder dystocia. We can see how the anterior fetal shoulder is lodged under the maternal pubic symphysis. All right, now let's discuss diagnosis. Screening for GDM is done with a 1-hour glucose challenge test. It's performed at 24 to 28 weeks gestation. The test involves the ingestion of 50 grams of glucose dissolved in water, 1 hour after ingestion. If the blood glucose is at least 140 milligrams per deciliter, it's considered to be a positive result. A positive result, in turn, needs confirmation with a 3-hour glucose challenge test. Now we'll review the 3-hour glucose challenge test, which is a confirmatory test for GDM. 100 grams of glucose is dissolved in water and then ingested by the patient. The blood glucose is measured when the patient is fasting and then 1, 2, and 3 hours after ingestion. Glucose cutoff values for this test are greater than 95 for fasting glucose, greater than 180 for 1 hour, greater than 155 for 2 hours, and greater than 140 for 3 hours. If 2 or more of these 4 criteria are met, then the diagnosis of GDM is confirmed. All right, let's try another question. A pregnant woman at 20 weeks of gestation has a blood glucose measurement of 120 1 hour after ingesting 50 grams of glucose dissolved in water. What is the best next step in management for this patient? All right, this patient has a negative 1-hour glucose challenge test because her blood glucose measurement is less than 140. Therefore, we just need to continue her expectant management without the need for a 3-hour glucose challenge test. Okay, shifting gears, let's now focus on the treatment. The first-line therapy for a mother with GDM is a diet low in carbohydrates and mild to moderate exercise. Exercise is beneficial because it upregulates GLUT4 expression in adipose tissue and skeletal muscle, resulting in increased glucose uptake by these tissues. If diet and exercise are insufficient, then we add insulin. Metformin and sulfonylureas are occasionally used by some physicians. However, their use is not a standard of care yet. As for the fetus, we need to regularly perform fetal ultrasound to monitor for complications. Additionally, we might need to perform cesarean delivery during labor due to fetal macrosomia. Okay, now let's discuss follow-up. Insulin is no longer required after delivery because by definition, GDM is supposed to resolve after birth. However, we have to ensure resolution of GDM with the 2-hour glucose challenge test. In this test, 75 grams of glucose dissolved in water is ingested by the patient. The blood glucose levels are then measured 2 hours after ingestion. If glucose is less than 140, this confirms the resolution of GDM. If the glucose is from 140 to 199, this indicates prediabetes. And finally, if the glucose is greater than or equal to 200, this indicates persistent diabetes. Okay, so far we've covered gestational diabetes and some fetal complications. Now let's move on to discuss pregestational diabetes mellitus. Here is a reminder of the sequence we'll follow in describing this condition. Pregestational diabetes is a type of diabetes mellitus that starts before pregnancy or within the first 20 weeks of gestation. Pregestational diabetes can be either type 1 or type 2. Let's remind ourselves that type 1 is an autoimmune process characterized by pancreatic beta cell destruction. On the other hand, type 2 is caused by insulin resistance. Okay, now let's discuss some risk factors. First, family history contributes to the development of both type 1 and type 2 diabetes mellitus. Secondly, obesity is a well-documented risk factor. Finally, the presence of other autoimmune disorders such as Hashimoto thyroiditis or SLE, predispose the patient to having type 1 diabetes mellitus. All right, now let's talk about clinical features. Signs and symptoms of pregestational diabetes in the mother are those that we classically associate with diabetes, such as polydipsia and polyuria. Interestingly, fetal clinical features of pregestational diabetes mellitus differ from those of gestational diabetes mellitus because in this case, the fetus is exposed to maternal hyperglycemia right from the first trimester. Specifically, pregestational diabetes mellitus can cause spontaneous abortion. Additionally, it can cause congenital cardiac defects, such as transposition of great vessels or transient hypertrophic obstructive cardiomyopathy. Pregestational diabetes mellitus is also known to cause small left colon syndrome in babies. Finally, there are 2 very rare complications in the fetus, which are caudal regression syndrome and serenomelia. Caudal regression syndrome is characterized by hypoplastic or absent sacrum and lower extremities. On the other hand, serenomelia, also known as mermaid syndrome, is characterized by medially fused lower extremities. Here we see an illustration showing transposition of great vessels. This is caused by an inability of the aorticopulmonary septum to spiral. Consequently, the aorta comes out from the right ventricle, while the pulmonary trunk comes out of the left ventricle. This is an image describing hypertrophic cardiomyopathy, And briefly, we can see here that the interventricular septum is asymmetrically hypertrophied towards the lumen of the left ventricle. While most cases of hypertrophic obstructive cardiomyopathy are hereditary, this condition in an infant of a diabetic mother is not hereditary, and what's even more important is that it's transient. Increased insulin levels cause glycogen and fat accumulation in fetal tissues, including the interventricular septum, making it asymmetrically hypertrophic. After birth, the baby is no longer exposed to maternal hyperglycemia, so insulin levels gradually return to normal. Glycogen and fat accumulated in the interventricular septum are slowly consumed by normal myocytes, and finally the septum returns to its normal size. Here we see a baby with sirenomelia or mermaid syndrome. Note the fused lower extremities. All right, let's get back to pregestational diabetes and review how we diagnose it. So if diabetes mellitus is not diagnosed before conception, we should measure hemoglobin A1C in the first trimester. If this is greater than 6.5%, it's diagnostic. Hemoglobin A1C is the preferred test to diagnose diabetes mellitus in pregnancy because it shows us the average glycemic control over the past 3 months. All right, moving on to treatment. As you can see, this slide is not much different compared to the one that we discussed while talking about the treatment of gestational diabetes mellitus. So the treatment for pregestational diabetes is a diet low in carbs and mild to moderate exercise. If the mother used to be on insulin before pregnancy, she should increase the insulin dosage while pregnant due to the diabetogenic effects of human placental lactogen. As for the fetus, we need to regularly perform fetal ultrasounds to monitor for diabetic complications in the baby. Additionally, we might need to perform a cesarean delivery during labor due to fetal macrosomia. All right, lastly, let's discuss follow-up. We should continue glucose monitoring in the mother after delivery. The insulin dose should also be decreased after birth because human placental lactogen is no longer increasing insulin resistance in a non-pregnant woman. All right, let's wrap up with a final question. A 32-year-old G2P1 female comes to the physician at 27 weeks of gestation for a routine prenatal visit. She has no specific complaints. Past medical history includes gestational diabetes mellitus in her previous pregnancy, which resolved after delivery. Her vital signs include a temperature of 96.8 degrees Fahrenheit, a blood pressure of 125/70 millimeters of mercury, a heart rate of 92 beats per minute, and a respiratory rate of 16 breaths per minute. Physical exam shows a fundal height of 27 centimeters. A 1-hour glucose challenge test shows a blood glucose level of 150 milligrams per deciliter. She also undergoes a 3-hour glucose challenge test that reveals a fasting glucose of 110 milligrams per deciliter, a 1-hour glucose level of 200 milligrams per deciliter, a 2-hour glucose level of 140 milligrams per deciliter, and a 3-hour glucose level of 130 milligrams per deciliter. Which of the following is the most likely effect of this patient's condition on her baby? A. Klumpke palsy, B. Small left colon syndrome, C. Transposition of great vessels, or D. Sirenomelia. All right, this question focuses on the fetal complications of maternal diabetes. First, we need to find out whether this patient has diabetes at all. She has a past medical history of gestational diabetes mellitus in her previous pregnancy, which resolved after delivery. This means that if she has diabetes now, it cannot be pregestational diabetes because her hyperglycemia resolved before her current pregnancy. Then the question is, does she meet the criteria to be diagnosed with GDM? As we explained in this lecture, GDM is diagnosed if 2 or more criteria of the 3-hour glucose challenge test are met. She meets exactly 2 criteria. That is, her fasting glucose is greater than or equal to 95, and her 1-hour glucose is greater than or equal to 180. Therefore, she has GDM. Now we should select the complication which can occur in GDM. Out of these 4 options, the most specific complication for GDM is option A, Klumpke palsy. Can cause fetal macrosomia with resultant shoulder dystocia. Shoulder dystocia, in turn, can cause the brachial plexopathy, including Klumpke palsy. So the correct answer is A, Klumpke palsy. Here is the slide that we discussed earlier, reminding us of several complications of gestational diabetes mellitus, including Klumpke palsy. All right, now let's discuss why the other options are incorrect. Option B, small left colon syndrome. Option C, transposition of great vessels. And option D, sirenomelia, all happen if a fetus is exposed to maternal hyperglycemia in the first trimester. In other words, complications B, C, and D only happen in pregestational diabetes mellitus. This patient, on the other hand, has gestational diabetes mellitus. So again, the correct answer is A, Klumpke palsy. And that concludes our lecture on diabetes during pregnancy.